Hello, colleagues, and thank you for joining us today. I'm Paul Karpecki of Kentucky Eye Institute in Lexington, Kentucky, specializing in cornea and external disease. In January 2025, Dr. Priya Gupta and I published an article in the journal Cornea entitled Comprehensive Assessment of the Meibomian Glands by Meibography, Why the Upper Eyelids Matter. This article challenges a fundamental assumption in our field, that lower lid meibography alone provides adequate diagnostic information. We routinely image the lower lid because it is convenient and easier to evert, but the upper eyelid frequently reveals earlier, more severe, and more clinically predictive changes across a range of conditions, from contact lens dropout to cataract surgery-induced dry eye, Sjogren's syndrome, and even thyroid eye disease. Over the next several minutes, I will share the evidence showing why evaluating both eyelids provides a more complete picture of meibomian gland health and how upper lid meibography can change our clinical decision-making in real-world practice. I will also address practical considerations, technique, time efficiency, and workflow, so this can be implemented in a busy clinic. My goal is that you leave this session ready not only to adopt upper lid assessment in your own practice, but also to advocate for it in your teaching, publications, and presentations. Let's begin. Here are three key statements that frame our discussion, each supported by the literature. There is a lack of strong association between the upper and lower eyelids in terms of meibomian gland morphology and function. Changes in one lid do not reliably mirror changes in the other. Number two, because of these morphological differences, assessing only the lower eyelid provides an incomplete and often misleading clinical picture in many ocular surface conditions. Third, taking the extra time to evaluate each eyelid separately is worth the chair time. It leads to more accurate diagnosis, better patient education, and more appropriate management. Let me translate what this means clinically. When you image only the lower lid and see mild changes, you may feel comfortable and offer conservative therapy. But if upper lid imaging reveals significant tortuosity, dropout, or central gland loss, you're suddenly dealing with a very different disease stage that warrants earlier and more aggressive intervention. This is not a suitable distinction. It is the difference between watching a patient progress to advanced meibomian gland dysfunction versus intervening when glands can still be preserved. Upper eyelid meibography is particularly valuable for early detection and risk stratification in four major areas: contact lens dropout, cataract surgery-induced dry eye disease, Sjogren's disease, and thyroid eye disease. In each of these conditions, upper eyelid changes often precede, exceed, or better predict clinical problems than lower lid findings alone. Before we dive into each one, I want you to consider a simple question. What percentage of your meibomian gland dysfunction patients are you imaging bilaterally, upper and lower eyelids, today? In most practice I visit, that number will be less than 50%. That means we are potentially missing critical diagnostic information in a large proportion of patients. The evidence I'll share with you today shows that bilateral assessment is not a nice-to-have. It is essential for accurate diagnosis, proper risk stratification, and optimal outcomes. Let's start with contact lens dropout, which is frustrating for both patients and practitioners. Data from the CLASS study group demonstrated that worsening upper eyelid meibum quality, gland plugging, and especially gland tortuosity significantly increased the risk of discontinuing lens wear because of discomfort. While lower eyelid glands tend to be wider anatomically, this feature does not translate into a clinically meaningful predictor of lens success. It is the upper lid metrics, particularly tortuosity, that emerge as strong risk factors for dropout. In my own practice, when a patient presents with contact lens intolerance, I now routinely perform upper and lower eyelid meibography. If I see significant upper eyelid tortuosity, even when the lower lid looks acceptable, I change the conversation. I explain, your lower lid glands look relatively healthy, but your upper eyelid glands show mechanical stress from lens wear. Without intervention, you are at high risk of losing lens comfort over the next several months to years. I share the images side by side, upper and lower eyelids, and use them to provide evidence to why they should or motivate them to using lid hygiene, omega fatty acid supplementation, heat or thermal therapies, prescription medications, and other maintenance strategies. This visual education significantly improves compliance and has helped extend successful lens wear and reduce dropout. If you are not imaging the upper eyelid in your symptomatic contact lens patients, you may be missing the key predictor of long-term success. Now let's move from contact lenses to one of the most common procedures we deal with, post-cataract surgery, dry eye. Cataract surgery is one of the most frequently performed procedures in North America, yet postoperative dry eye symptoms remain a common source of dissatisfaction. Evidence shows that preoperative upper eyelid meibomian gland loss is a significant predictor of postoperative dry eye symptoms in the early phase, whereas lower lid gland loss often does not correlate as strongly. Subjective dry eye onset after surgery tracks closely with baseline upper lid loss, suggesting that upper lid changes can precede and outpace lower lid disease. Based on these findings, I have modified my preoperative protocol. Every cataract patient candidate now receives upper and lower eyelid meibography, alongside topography and macular imaging. Patients with more advanced upper lid changes, those with moderate to severe gland loss, are flagged as high risk. For those patients, I initiate proactive treatment 4 to 6 weeks before surgery. That might include thermal pulsation, intense pulse light treatments, dedicated lid hygiene, and where appropriate, prescription anti-inflammatory therapy or Demodex blepharitis treatments. The results have been a noticeable reduction in early postoperative dry eye complaints and higher satisfaction scores. I would encourage you to consider bilateral upper and lower lid meibography as part of your standard pre-op cataract workup. The incremental time is modest, on the order of 20 to 30 seconds per patient, but the impact on postoperative comfort and quality of vision can be substantial. Now let's look at Sjogren's disease, a systemic autoimmune disease with profound ocular surface implications. Several studies show that upper eyelid meibomian gland dropout is significantly higher in Sjogren's patients than in non-Sjogren's dry eye. These upper lid changes appear early and likely contribute to the more severe refractory nature of this population. Upper lid meibography has become an important component of my Sjogren's screening algorithm. When a patient has severe dry eye, high symptom scores, low tear production, diffuse corneal staining, and conjunctival staining, often more on the temporal location, I see marked upper lid gland dropout that is disproportionate to lower lid findings. Sjogren's moves to the top of my differential diagnosis. That imaging pattern alone does not diagnose Sjogren's disease, but it raises my index of suspicion and prompts referral for serological testing and a rheumatology evaluation. Early identification can change the trajectory of disease, not only for the ocular surface, but for systemic manifestations as well. For those of you who train residents and fellows, consider making upper lid meibography a standard part of your teaching on autoimmune dry eye. It is a clinical pearl that many training programs still overlook. Finally, let's touch on thyroid eye disease, where the upper lid once again tells a critical part of the story. Thyroid eye disease is another condition where upper eyelid meibomian gland status provides valuable clues. Patients with thyroid eye disease often show significantly higher upper lid meibo scores and central gland dropout compared to other dry eye cohorts. These changes are influenced by factors such as incomplete blinking, proptosis, and lid retraction, and they correlate with ocular surface inflammation and oxidative stress. From a diagnostic standpoint, this has real implications. When a patient presents with chronic dry eye complaints and I see prominent upper lid gland loss, especially if it is central, asymmetric, or accompanied by subtle lid retraction, I now routinely ask about thyroid history and systemic symptoms, even if there are no dramatic external signs. This approach has led to earlier detection of thyroid dysfunction in patients who might otherwise have been managed as routine dry eye. It reinforces our role not only in treating the ocular surface, but also in identifying systemic disease early and coordinating care with endocrinology and oculoplastics. A comprehensive assessment of both upper and lower lids helps distinguish thyroid-related ocular surface disease from other forms of dry eye and supports a more targeted management. At this point, some of you may be thinking, this all sounds compelling, but I'm already running behind in clinic. How do I fit this in? Here's the workflow that has made upper lid imaging sustainable in my practice. For any patient with dry eye symptoms, contact lens wear, or preoperative evaluation, we routinely evert and examine the upper lid as part of the slit lamp exam. It adds only a few seconds. Using modern imaging systems, my staff can capture both upper and lower eyelids in a single session. With proper training, technicians handle the aversion and capture, while I focus on interpretation and clinical decision-making. The total additional time per patient is approximately 20 to 30 seconds, and once the protocol becomes routine, it no longer feels like an add-on. It becomes part of the standard exam, like checking intraocular pressure. The key point is that technical barriers have largely been solved. With current tools and a consistent protocol, upper lid meibography is efficient, reproducible, and scalable to any busy practice. We've talked about the evidence, the clinical impact, and the practice workflow. Let me leave you with 3 specific action steps. First, for your own practice. Start next week by committing to performing bilateral upper and lower eyelid meibography on your next group of meibomian gland dysfunction or dry eye patients. Pay close attention to how often the upper lid findings alter your diagnosis or management plan. Many clinicians who make this change are surprised at how frequently upper lid imaging influences their decisions. Second, for your teaching. If you are involved in residency, intern, or fellowship training, make bilateral eyelid eversion and imaging a required skill. The more we normalize upper lid assessment during training, the faster it will become standard. We should reach a point where imaging only the lower lids feels as incomplete as examining only one eye. Third, for your advocacy. In your next lecture, article, or panel discussion, include this evidence and highlight the role of the upper eyelid. The cornea publication provides the peer-reviewed foundation to support this message. As KOLs, you are in a unique position to accelerate adoption of comprehensive meibography across the professions. The upper eyelid is not just another lid. In many of our patients, it is the key to early detection, accurate diagnosis, and optimal outcomes. The science is strong, the tools are available, and the workflow is manageable. What we need now is broad clinical adoption, led by colleagues like you. Thank you for your time today. I hope you will utilize this information to enhance your practice, to help students and colleagues, and to advance the care that will ultimately have the biggest impact on your patients and dry eye. Consider the publication and the evidence present around contact lens dropout, something that would be wonderful to identify early, and upper eyelid meibography helps that. This also applies to post-cataract dry eye, Sjogren's disease identification, and thyroid eye disease.